I'm going to invite you to close your eyes for a moment and try to imagine yourself as a brand new parent holding your newborn. Maybe you can imagine how your baby smells, feels, or sounds. I wonder what it is like to hold your newborn for the first time, to kiss him or her, to soothe him or her when distressed. Now I want you to fast forward a few years. Your baby, now a toddler, is refusing to try foods, has trouble falling asleep at night, has delayed language development, is failing to play with toys in imaginative ways, ignores his or her peers, and takes comfort in lining up his blocks in the same color pattern every time. Your now toddler is soon to be diagnosed with autism. Alternatively, years pass and misdiagnosis after misdiagnosis is made. After years of seeking the wrong supports and treatments, your child is diagnosed as being on the spectrum. As a parent, you're thrown into a world where you have to make the best possible decisions for your child with limited understanding and education. You, as any parent, are determined to do the best you can for your child. Now, I'm going to ask you to imagine that you are your child. You are receiving a range of treatments. You go to daycare, preschool, or school. Maybe you have SLP sessions, OT sessions, play sessions, or ABA sessions. The goals across all these environments are for you to learn. Learning, though, comes at a cost. As part of your interventions, you're being told no thousands of times a day whenever you make a mistake. On the surface, a harmless practice when teaching. For some, this might be a trauma. Now I'd like you to imagine yourself in your child's shoes again, engaging in self-stimulatory behavior to calm your nervous system when you're overwhelmed. Yet this behavior, which could be seen as adaptive for your child, is redirected or stopped in some way because it looks socially inappropriate. Now imagine you fast forwarded to adulthood, and your child reports on the harm that interventions aimed at reducing self-stimulatory behaviors were harmful to him or her. Now imagine yourself in your child's shoes being locked in a small room or closet in a school because their behavior is deemed to be unsafe to staff, children, or themselves. Imagine being nonverbal and being abused by a caregiver, someone who's trusted to teach you and to keep you safe. You cannot articulate your experience. Your only way to communicate this abuse is through your behavior. However, your behaviors are seen as symptoms of your diagnosis of autism. Now maybe imagine falling victim to bullying at school. Every day you walk in fearfully to your high school, knowing your perpetrators are lurking in the hallways, waiting for you. You fall victim to ongoing physical and relational bullying at your school for the entirety of 5 years. Or maybe, tragically, you're a victim to some form of abuse at home. Now imagine your whole world as you know it ground to a halt this past year. You no longer go to school daily where you receive support from your team. You no longer have your intervention or therapy sessions. Your extracurricular activities have suddenly all ended. You can no longer connect with your peers. You're expected to keep some magical 2 meters apart from others. You're expected to wash your hands all the time all of a sudden with no understanding as to why. You're asked to wear masks. You see people wearing masks. You're experiencing sudden isolation. Your parents are maybe suddenly unemployed and your family's resources are depleting. Stress in the family home is increased and you cannot make any sense of it. Each one of these experiences is a trauma or could be experienced as a trauma. Yet, until very recently, the concept of trauma and its effects on individuals on the spectrum has not been studied, treated, nor even spoken about. So, our learning objectives for today are to define trauma and discuss its impacts on individuals with autism, discuss how symptoms of trauma can present themselves in individuals with autism, discuss and apply how to work in conjunction with an ABA-based intensive intervention program, discuss applications from Trauma-Focused ACT, acceptance and commitment therapy, and discuss applications from trauma-focused cognitive behavioral therapies. Some of you may know this to be the mover and shaker Ryan O'Donnell, who's a behavior analyst and runs the Daily BA. This is an extremely important caveat for all of you, as our shared common interest is in serving individuals with autism. Regarding the literature based on trauma as it affects individuals with autism, you'll repeatedly hear today that there is a paucity, a dearth, a void, and an absence. Yet statistically, we know that a trauma is extremely common. In a seminal article in 1998, published by Folletti, they aimed to establish a connection between experiences of childhood abuse or traumas and medical illnesses in the general American population. It was found that if you have a mic on, would you mind turning your mic off if that's possible? So in the 1998 Folletti study, he found that rates of adverse childhood experiences, known as ACEs, indicate that about 52% of the population experienced at least one childhood trauma. Of those who experienced one ACE, the probability of exposure to a second ACE was between 65 and 93%. And likelihood of two or more ACEs was between 40 and 74%. So what about in children with ASD? Prevalence rates are unknown as a result of a direct lack of screening tools for trauma in children with autism. In a paper that Dr. Lucician and I published in 2018, we note that we can make some inferences about increased vulnerabilities to trauma. We note that individuals with developmental disabilities may be at greater risk for being maltreated as compared to their typical peers, and children with developmental disabilities struggle with their communication skills, are more likely to be socially isolated, and are prone to experiencing high levels of familial stress. These factors are common in individuals with autism spectrum disorder and make them even more susceptible to maltreatment. So why do we care about ACEs and what are they? The Folletti study in '98 set the groundwork for the emergence of research in a broad array of disciplines such as endocrinology, neurobiology, medicine, psychology, psychiatry, and so on. Prior to 1998, we really knew very little about trauma, its symptoms, and sequelae. What has been shown since the seminal study are that ACEs, as a result of the chronic stress endured by the individual on their body, are directly related to both medical illnesses such as heart disease, cancers, obesity, autoimmune diseases, early pregnancies, and STIs, as well as to mental health illnesses and behaviors such as addictions, delinquency, depression, anxiety, OCD, ADHD, and an increased likelihood of dying from suicide. So then what are the ACEs? Here is a general list of ACEs for you. They involve psychological abuse, physical abuse, sexual abuse, emotional abuse and neglect, physical neglect, loss of a parent for any reason, being separation, death, divorce, being placed to foster care, and so on, a mother or a father being treated violently in the home, substance abuse, and mental illness within the home, as well as criminal behavior in the household. What is trauma then? So there are many definitions. Trauma can be categorized into a physical trauma, such as a car accident, an injury, premature birth, medical illnesses, and there are also psychological traumas like those that were listed on the previous slide for you. There are many definitions of psychological trauma, and a couple that resonate for me are the two that I've pulled up for you here. So Gabor Mate defines it as a wound. Alternatively, a slightly more tangible definition that Kearns et al. Published in 2015 is that a trauma is a psychological injury that causes damage or harm to the person and which varies in terms of its permanency, severity, and longevity. Traumas can be placed on a spectrum of severity. On one end of the spectrum, a trauma can be minor and easily overcome, occurring only one time, such as an instance of bullying by a peer. On the other end of the spectrum, trauma can be severe, long-lasting, and may require professional help to heal from, such as any form of abuse or the death of a parent, witnessing violence, and so on. The repercussions of severe trauma are well known to alter one's life functioning, and if left untreated over time, can lead to the development of post-traumatic stress disorder or complex post-traumatic stress disorder. So the impacts of trauma are varied across individuals. They can have a minimal impact or a severe impact. For example, Andrea may have incurred ongoing bullying from a teacher as a child and come out of that just fine, unscathed. I, on the other hand, may have also experienced ongoing bullying by the exact same teacher the exact same year, but I came out of that year traumatized from it. When trauma is left untreated, the individual's quality of life suffers. So what you see here is a funnel, and I want you to imagine this to be the funnel kind of your life. So if you can, when you've lived your life relatively unscathed, meaning you've had challenging experiences, but not many traumas, then you can easily live kind of at the top of this funnel on the outside of it. You can enjoy the world. You tend to have a life full of rich experiences, and you're open to new relationships. The deeper that you start to go, the more trauma affects you. So sometimes we start to see some inflexible behaviors emerge or fewer flexible behaviors. You may become inflexible to new experiences. You may be estranged from some family and only have a small amount of family in your life. You may have only few friends. You may experience flashbacks, anxiety, fear, nightmares, not having any friends whatsoever, engage in self-injury, suffer from depression, incarceration, suicidal ideation, and death from suicide. The longer that trauma is left untreated, the more pervasive some of these problems will become. So little is known about the impacts of trauma on children with autism, which is what I was saying at the start. However, given the research in typically developing children clearly shows a range of detrimental effects, we need to start to infer that children with autism will be impacted in some of the same ways by trauma, and possibly in different ways as well. Although little is known, I'm going to walk you through what we do know about the impacts of trauma on typical development and what we do know in terms of its effects on the development of children with autism. So we'll look at neurobiological effects, emotion regulation, cognitive development, and behavioral symptoms and how they're affected in children with autism specifically. So we could spend all day learning about the neurobiological effects of trauma. There's obviously not enough time for this, so I'm really going to run you through this quite quickly and on a very superficial level today. But we know that the limbic system is involved in the processing of trauma. The limbic system is involved in emotion processing and regulation, especially with those emotions that pertain to survival, so fear, anger, hunger, and sexual behavior, as well as with learning and memory formation. The limbic system is comprised of the amygdala, the thalamus, the hypothalamus, and hippocampus, as well as a group of other small structures. In terms of typical development, it is well established in the literature on typical development that exposure to repeated traumatic events or chronic trauma can cause changes in a person's neural structures and sensory systems. Environmental threats are detected by the prefrontal cortex, amygdala, and the hippocampus. So when there's a psychosocial threat that is perceived, the hippocampus and prefrontal cortex activate the firing of the amygdala. The amygdala then triggers a region of the brain that in turn activates the sympathetic nervous system, so the fight versus flight response in people. The amygdala plays a role in emotional processing and in developing a fear response. Its role is to evaluate whether stimuli are potentially threatening to the individual, and signals that are sent by the amygdala to the brainstem begin startle responses and initiate defensive behaviors, such as fight, freeze, and flight behaviors. From a behavioral perspective, we can look at this in terms of a very broad range of stimuli in the environment that can evoke feelings of fear, but can sometimes be seen in overt behaviors such as refusing to try new things, refusals to enter public spaces, insistence on routine because change evokes the fear, elopement, crying, selective mutism, and so on. So to touch on a couple of things that we do know in relation to kids with autism, we know that children with autism have higher levels of salivary cortisol in response to novel and threatening stimuli. As well, children with autism exhibit elevations in salivary cortisol levels when anticipating re-exposure to perceived stressors. These pre-existing inherently weak stress responses may increase the vulnerability to future experience of trauma, or increase traumatic responses to environmental stimuli in individuals with autism. Such responses may in turn initiate a cycle of biological and behavioral dysregulation in kids on the spectrum. So essentially what we are saying here is that the underlying biology of children with autism may predispose them or make them more vulnerable to experiencing some events as traumatic, whereas a neurotypical may not experience a particular event as a trauma. So typical development and trauma in regards to emotion regulation. So ER can best be understood within the framework of a biopsychosocial model. ER refers to a group of processes that work together so that the individual can appropriately react and modify one's emotional response to meet a variety of situational demands. There are two main ways that people typically regulate their emotions: through cognitive reappraisal and expressive suppression. Cognitive reappraisal is a strategy that involves cognitive changes and is seen to be adaptive. This is like rewriting your narrative of the experience and being flexible in how you think and talk about the experience in the future. You can think of it almost as a perspective shift of the traumatic event. Expressive suppression occurs when the person modulates the expression of the emotional response, meaning they attempt to suppress the feelings associated with the trauma, push them away, or at times dissociate from them. And when used as a primary method of emotion regulation, it's believed to be maladaptive. For those who've experienced a trauma or repeated pervasive trauma, there are a range of responses to trauma that may occur on the spectrum from hypoarousal to hyperarousal. Hypoarousal and hyperarousal refer to the nervous system and how it responds in the face of trauma. And Andrea will touch a bit more on this when she provides a case study example. So in states of hypoarousal, the individual dissociates or disembodies, and according to the American Psychological Association, dissociation occurs when an individual is experiencing a traumatic event, such as victimization, abuse, or experiencing a crime, and leads to a disconnection between the person and his or her environment in circumstances where the trauma is more than she or he can tolerate. An individual can dissociate the memory of the place in which the trauma occurred, the memory of the trauma itself, and they can also dissociate from the emotions about the event. Hyperarousal refers to the fight response in trauma. When it comes to autism and trauma and emotional regulation, very little is known in regards to emotion regulation in individuals with autism who've also been exposed to traumatic life events. Now, in terms of cognitive development, when looking at research with children who are typically developing, some researchers argue that a calm physiological state is required for optimal learning conditions. In fact, Van der Kolk and colleagues argue that the heightened states in traumatized children can lead to learning challenges. Children who are traumatized may overly attend to sources of threat in their environment, leaving them in states of hyperarousal for extended periods of time. In turn, this leads to generalized learning problems and struggles with overall academic achievement and maladaptive behaviors. Again, in terms of children on the spectrum, there is a dearth of literature in regards to the effects on learning and trauma. In terms of behavioral symptoms in children with autism, we do have a little bit more knowledge here. In 2017, Brenner and colleagues conducted the first exploratory study where they looked at the behavioral symptoms of PTSD with a sample of children with autism whose parents or caregivers reported histories of abuse with the children. They found that children with autism with a reported history of abuse and comorbid diagnosis of PTSD reported more fear, tantrums, intrusive thoughts, and upsetting memories. The data from this study suggested that children with autism experience similar symptoms to those that meet the criteria for PTSD, but that there is an overlap in symptoms in children with autism who do and do not have reported histories of abuse, making that discrimination of symptoms very challenging to make, in fact. And they argue that diagnostic overshadowing may have been at play in this population when diagnosing PTSD in a sample of children, as children with autism in general present with those complex emotional behavioral symptoms. So diagnostic overshadowing occurs when symptoms of one disorder or disability or illness are really similar to those of another one, and it makes it very difficult to tease apart the symptoms, and so we end up with an underdiagnosis of comorbid disorders. So for example, when we look at the symptoms of individuals with autism, we see that they share very common features to those who've incurred trauma and those who have symptoms of ADHD as well. In terms of assessment, as with the general paucity of the literature in this area, there are no psychometrically validated assessment instruments used to evaluate for history of symptoms in trauma in children with autism. So some general guidelines were offered by Kearns et al. In their paper in 2015, and some of their recommendations were that they noted that the quality of traumatic events and responses to trauma may vary in children with autism. Therefore, measures designed to assess a broader array of trauma-related symptoms may be more relevant than those that are more specific. As well, they note that assessment of PTSD in very young children suggests that assessment criteria should be behaviorally based and developmentally sensitive to detect trauma in young children with ASD who may have delayed abstract cognitive and verbal expression abilities. Symptoms such as flattened affect and social detachment may be difficult to discriminate as symptoms of trauma in children with autism, as many individuals on the spectrum don't express emotions the same way and are also socially isolated. And then in the recent chapter that I was mentioning at the beginning that Joe and I wrote, we recommended the use of simplified language to address language deficits and the use of pictures to facilitate comprehension of trauma-related concepts when directly asking children about trauma. So in our 2018 paper, we generated a possible treatment model of trauma in children with autism. Looking at this today, I would be inclined to include more components that are rooted in acceptance and commitment therapy-based approaches. But in any case, in our model, we had key components of the treatment package on your left, and then some examples of variables that should be considered for individualization when working with clients of varied abilities on the right. I'm only going to review those components. It's in some level of detail that can really help you guys build better trauma-informed positive behavior support plans and improve your practice for learners so that they may be better trauma-informed today. Andrea will give you a couple applied examples of this, and Bobby will provide more details around the how of treating trauma specifically. So in general, when practicing from a trauma-informed perspective, we consider our individual client in the whole context of their life. We see that they are complex as a result of their learning histories, that they have thousands of overlaying relational frames at the point that they come into our lives for treatment, and that we have to treat clients taking into consideration what happens within the skin, so private events, as much as we consider behavior outside of the skin. When we see the client in this light, we start to take on a trauma-informed perspective. So the first part of the treatment package is that we conduct a functional behavior assessment. Many children who have incurred traumas engage in problem behaviors. So we recommend conducting an FBA to determine the function of the problem behavior. The FBA will then inform the development of a positive behavior support plan. It's very important to determine the relationship, if any, between behavior problems and the child's trauma. So the FBA can possibly help to identify specific antecedent triggers for trauma-related problem behaviors and also the function of trauma-related behavior. So really quick caveat, in some cases, it might be almost impossible to control for all the variables that act as antecedents for problem behavior in relation to trauma, as the stimulus class can be exceptionally broad. As well, sometimes the trigger is a private event or inner behavior in the form of a memory or a flashback that can be very hard for
Hello, Bonnie speaking.
Yes? Oh, I think that somebody was picking up
hi.
the phone.
Good, how are you?
As well, sometimes the trigger is a private event or inner behavior in the form of a memory or flashback that can be very hard for an individual on the spectrum to articulate. In any case, what we are aiming to see emerge from an FBA, for example, would be to see that self-harm, tantrums, or sexual behaviors triggered by memories of trauma serve the immediate function of reducing the trauma-related memories. It's also important to assess for whether or not problem behaviors occurred prior to the trauma or if they emerged following the traumatic experience. And then the other key component here is if the behavior problems predated the trauma, then you may want to assess for changes in regards to the rate of the behavior, the intensity, or the topography of the behavior. In terms of behavior support plans for parents and behavior interventionists, the client's whole community may require support. Working within a trauma-informed framework, your PBS plans or BSPs need to take into consideration how best to support all aspects of the team. I'm not going to go into many details here, as Andrea is really going to give you some hands-on examples of what this is going to look like. So I'm just going to skip ahead right now for the purposes of time. But in terms of also for behavioral skills training and for parents and BIs, this is also really a component that's specific to the treatment of trauma itself. But for anybody working within this framework, it's important to collect data, monitor the data, make ongoing good database decisions. And something that you're going to see Andrea talking about is going to be an image of the standard acceleration chart. So I'm not really going to walk you through all the details here, but I just wanted to show you an image of what some of her data may look like. And she will basically tell you before each chart whether we're looking for accelerating data, decelerating data, or possibly data that's high and flat, but that's also a positive indicator of good learning. So in terms of teaching emotion regulation, So when we work with very young children who have not yet developed self-regulation skills, we teach regulation through co-regulation. Co-regulation is when the stress cycle is completed with the support of a safe enough person. A safe enough person is someone who is in a calm state of social engagement. They're able to breathe deeply. They have a soft gaze, expressive face, calm heart rate, a prosodic voice, and have the ability to enjoy closeness. And they can serve as a really good role model for regulating one's emotions. So again, Andrea will give you an applied example of how this was used with some of our learners. For older learners, we teach ER through mindfulness practices and PRT practices. When teaching mindfulness techniques specifically to our learners, we recommend the use of multimedia to enhance instruction. So we might use videos or apps to do this. Sometimes for learners that require increased visual supports, we add them to our practices as well. So we may, for example, if a learner has a hard time identifying different parts of the back, we might have a visual that has an image of the lower back, the mid back, and the upper back, for instance, and we'll pair that with our meditation practice. So another component that you may want to consider is your client's ability to endure sitting or laying for long periods of time. So you need to ensure that your instruction is modified based on their ability to endure long meditation practices. And then there are a range of different meditation apps that you can always download and check out yourself, such as Calm or Headspace or Settle Your Glitter. The next component is to teach emotion recognition. So a common side effect of trauma in all individuals is that what can end up happening is that individuals have a challenge with naming the emotions in other people as well as in themselves. So this can become even more impaired in individuals on the spectrum who quite frequently need explicit intervention in this area anyways. So as part of your programming, planning to explicitly name emotions across a broad range of stimuli is going to be imperative. Graduated exposure and increased number of sessions are very specific to how one would treat trauma within a modified trauma-focused CBT plan. So I'm going to skip over that for now. And similarly here, decreased session length, cognitive restructuring, and psychoeducation about trauma and trauma responses are all components that are specific to a treatment package for trauma. So I won't go into too many details here. The one thing I'm going to mention though is that in regards to cognitive restructuring, today, I think I'd be more inclined to take an ACT-based approach here and look at the concept of cognitive diffusion. So looking at thoughts more from the lens of us as humans not really having control over our thoughts, but rather acknowledging and accepting them as our inner behavior and happening automatically. The aim then is to see them from a different perspective rather than seeing ourselves as being equal or equivalent to our thought, which is much more of a cognitive flexibility practice. And Bobby, I believe, is going to spend some time explaining how diffusion techniques were applied to her case study. In terms of parent and child support between sessions and the development of safety plans, again, those are components that are very specific to the actual treatment of trauma. But like with anybody working with individuals on the spectrum, we do always need to make sure that we're programming for generalization and maintenance. So for example, if you teach mindfulness practices for emotion regulation, we need to ensure that we're teaching across a broad range of practices. If we are teaching emotion naming, then making sure you engage in general case programming is going to help ensure we've taught sufficient exemplars and that our learners will pass and they'll maintain and generalize their learned skills. So trauma is not a light topic. It can evoke some dark images and can feel hopeless at times, both when you're in it and for years after the event. So I thought I'd leave you with this famous Leonard Cohen quote: "There is a crack in everything. That's how the light gets in." Both Andrea and Bobby are going to show you that there is in fact light in all of this. And for many, there can be an experience of what is known as a post-traumatic growth. Most importantly, for all of us who have the privilege of working with individuals on the spectrum, we can walk away knowing that there is a way to make a difference in our clients' lives, even in the face of trauma.
There we go. Thanks, Alexia. Oopsies. So before, where is it? Okay, so before I start presenting the cases that we have prepared, I'd like to start with a quote. So back in February, Alexia, Bobby, and myself spent 4 days at an acceptance and commitment therapy boot camp in Portland. And on the final day, Dr. Stephen Hay shared a quote from Dr. Gordon Paul, a foundational scholar in the transformation of clinical psychology. Paul said, when questioning the goal of evidence-based interventions, what treatment by whom is most effective for this individual with that specific problem, under which set of circumstances, and how does that come about? So, I think we're missing a slide here. So I'm just going to read from what I've got here. So in this section, I'll review some case studies of 2 clients on our caseload. And in each case, I'll review their individual profiles, provide an overview of their developmental learning history, review the strategies and treatment package components used with each of these individuals, and discuss how we adjusted our teaching approach when they experienced triggering events and exhibited trauma symptoms and behaviors. I'll also share some outcomes following the treatment. So our first case study involves a teenager with a complex developmental history. The teen lives at home with their primary caregiver and attends a private school for youth with diverse learning needs. This teen has very few relationships and identifies as somebody who struggles to develop and maintain friendships. While they have a broad range of intellectual interests, they do not attend any extracurricular activities. So in terms of developmental history, this teen has a formal diagnosis of ASD and ADHD. They live in a single parent home with their primary caregiver, and caregivers share custody. However, there is estrangement from one of the caregivers. Around the same time as the estrangement began, the learner began to state that they did not recall details of their past, and they had no memories of the estranged caregiver. So with no apparent medical explanation for this memory loss, the teen was diagnosed with dissociative amnesia. Dissociative amnesia develops as the brain's way of coping when an individual has experienced extreme levels of ongoing stress or trauma. It's seen as an adaptive way of coping through excruciating life circumstances. Our learner intermittently receives services from an adolescent treatment center that offers specialized programs and services that address needs of youth with severe mental health concerns. They were first admitted for assessment and development of a care plan as a result of depression, anxiety, self-injury, suicidal ideation, aggression, and the caregiver estrangement. The care plan was developed by a team of mental health professionals in collaboration with the primary caregiver. So let's look back at the quality of life funnel that Alexia showed you guys. This teen has experienced a loss of enriching life experiences. They have few relationships. They're inflexible to new experiences. They've lost family members. They experience flashbacks. They battle anxiety. They have a history of engaging in self-injury. They struggle with depression. They have a history of suicidal ideation. And so as you can see, this teen's world has continued to just get smaller and smaller throughout their lifetime. So as a result of this teen's elaborate learning history, they've developed a complicated series of relational frames. So as Alexia mentioned, learning histories are comprised of hundreds and thousands of overlapping relational frames. One of the complications that we run into when working with teens and adults is we do not have as much detailed information about their learning history. When diagnoses come later in life, these individuals were not placed under the same microscope as young kids that we work with. So we're left to make inferences about what some of these frames might be and how we can reframe their experiences. Additionally, due to our own learning histories as professionals, we have our own relational frames. We create our own bidirectional links between our clients, their diagnoses, the behaviors that they engage in, and the functions of their behaviors. So here's an example of a very common relational frame that we might see for someone diagnosed with autism. An individual with ASD is presented a task by a parent, a caregiver, or a teacher. It could be something like a request to put away dishes, or an instruction to get ready for bed, or maybe a new homework assignment. Whichever it is, it might teach the individual that teachers, caregivers, and parents are people who give requests and have specific expectations of a learner. Then we may also see that task demands and requests are placed on the individual, and certain behaviors are effective at escaping or avoiding those task demands. We might see an increase in maladaptive behaviors and or withdrawals of assent in order to avoid or escape the task, such as saying, I'll do it later, walking away from people when the instruction's given, or leaving the homework assignment at school. So from this, the derived relationship developed is when there's a teacher, a caregiver, or a parent, the individual may engage in escape maintain behaviors or withdrawals of assent, even when requests or demands are not placed. So this might look like ignoring, walking away when people arrive, talking over them as soon as they arrive, etc. And it's very easy as professionals for us to look at our client with a history of escape maintain behaviors and infer that those maladaptive behaviors and withdrawals of assent are occurring as a way simply to escape task demands. So as a result, we might implement something like escape extinction or another form of differential reinforcement as a way to address and reduce the occurrences of that problematic behavior. But this can be really dangerous from a trauma-informed perspective because, as Alexia mentioned, a lot of symptoms and behaviors of trauma can be overshadowed by symptoms and behaviors of ASD. So we have to take a step back to stop and look at the relational frames that we have learned and begin to look at the same behaviors through a trauma-informed lens. So here's the same relational frame, but how it might be viewed through a trauma-informed lens. Complex PTSD symptoms begin to emerge as the result of an ongoing trauma. The relationship here is that people are unsafe and scary, and when people are around, symptoms of complex PTSD, like heightened anxiety or dissociation, occur as a conditioned response. It's important to note that environmental triggers are not always identifiable because environmental triggers can include private events or what some call inner behaviors. Private events can include thoughts, feelings, urges, or bodily sensations. And in the event of a trauma, the response is an unconditioned response. The unconditioned responses, such as fear or an urge to escape, is paired with other environmental stimuli, like people. These unconditioned responses become conditioned responses in the presence of other environmental stimuli. So in this example, when a person is present and is a threat to the child as a result of neglect or some other form of abuse, fear is elicited, and over time, fear is evoked in the presence of this person, regardless of their behavior. This biological response can act as a trigger. And when an individual is triggered by a stimulus in their environment, this may mean that the individual is unable to perform a task or engage with others. In this moment, the individual may withdraw assent, and when this withdrawal of assent is reinforced over time, withdrawals of assent become conditioned responses. So for example, when our learner is triggered by a private event, they may tell us that they need to use the washroom. This request to use the washroom is a conditioned response to their private event because they've learned that when these triggers occur, I need to stop what I'm doing so that I can get away from what has triggered me. So here, the derived relation is between people and withdrawals of assent. People are seen as unsafe because people are environmental triggers. And in order to avoid triggers, the withdrawal of assent occurs to keep oneself safe. Therefore, the presence of people evokes withdrawals of assent. Due to this teen's complex history of trauma, in addition to their diagnosis of autism, they've developed some very complex relational frames. Sometimes it can be very challenging to tease apart which withdrawals of assent are due to trauma and which are withdrawals of assent due to lack of interest in the task or lack of a potent reinforcer. This teen is very bright and has developed a very large response class of withdrawals of assent to both escape and avoid people and environmental triggers, as well as escaping and avoiding unpreferred or challenging tasks. They may use dissociation as withdrawals of assent if more appropriate withdrawals of assent are not reinforced. So for example, if this learner said, I don't feel like doing that, and we followed through because we thought that that was an escape maintain behavior, our learner might then dissociate. We can't know if that dissociation is because of a private event or if the dissociation is acting as a second withdrawal of assent. We've seen this learner close the computer to leave online classes at school because they say they're too anxious, or maybe they say that something happened at school that has upset them, and then as a result, they cannot focus during their session. So with this individual, there's very subtle nuances that we have to pay close attention to and constantly evaluate what might be happening throughout our sessions. One of the most important pieces of the care plan shared by the mental health team was to ensure that the main focus must be creating a space in which the learner does not become re-triggered. It is imperative to teach how they can be with people while also remaining calm and how to feel safe in learning environments. So our task before anything else was to help develop a new relational frame. The frame that we were aiming to create was that people are safe, feeling safe leads to a calm nervous system, and therefore being calm around people can occur while my nervous system also remains calm. So with this learner, trauma-informed behavior support plan, a positive behavior support plan was developed. Some components of the trauma-informed PBS plan included conducting a functional behavior assessment, developing a family support plan, a mental health care plan developed in collaboration with the mental health team, the use of non-contingent reinforcement before sessions to develop a trusting therapeutic alliance and relationship with our learner, using functional communication training to teach functional communication in the form of manding and tacting their inner behaviors and bodily sensations, and the use of social validity measures to evaluate the acceptability and satisfaction of program goals in sessions. In addition to the trauma-informed PBS plan, we also used a variety of the treatment components from the proposed treatment package in Alexia and Joe's publication, including teaching skill deficits, teaching emotion regulation using mindfulness, as well as modified acceptance and commitment therapy. One of the largest components of this team's program when we started with them was building a safe and strong relationship with team members. So for 2 months, only about 3 or 4 appointments, the learner's time with Alexia was spent simply building the relationship. They spent time walking in the community, discussing their shared interests and learning about one another. Once the one-to-one intervention sessions began, 30 minutes at the start was dedicated to the same relationship building practice. Prior to sessions, I would prepare a range of activities that the learner would enjoy and prepare those materials beforehand. And then at the start of the sessions, we'd select an activity together and we'd complete it for 30 minutes. During our relationship building time, we'd count the number of positive and negative statements made about the activities, as well as personal information shared and personal information questions asked. So if you look at the data across time, you can see that the learner made positive statements about the activities, and you can see that they share lots of personal information. Those are the closed dots and the hearts on the chart there. You'll notice that they never make negative statements about the activities, which are the X's, and those turn into question marks underneath our timings floor on a standard acceleration chart. You can also see on the chart that it only took us 4 sessions before we were able to cut the time on relationship building in half. And so after doing this, the learner asked if we could shorten this time again. And we decided to spend only 5 minutes at the start of sessions with relationship building exercises, and then use the activities that were planned as reinforcers throughout the session following the completion of other tasks. And in our last session before the holidays, the learner requested to skip this activity altogether. And they said that it was important to spend our time together working on their goals rather than just hanging out together. So we also track maladaptive behaviors and withdrawals of assent in sessions to ensure that our learner is calm and consenting to the activities in sessions. So the mental health team helped to define observable behaviors that occur when our learner dissociates so that we could track these and ensure that we're not the triggers for dissociation. What we're looking for here was to see a decrease in inappropriate withdrawals of assent in the form of dissociation, crying, and ignoring instructions from interventionists. These are the X's, the squares, and the triangles on the chart. At the same time, we want to see an increase in socially appropriate withdrawals of assent, which are indicated here by the hearts. There's a heart here and a heart here. You can see in the data here that there are days when the learner does need to withdraw assent, but there's also a rate of almost 0 maladaptive behaviors. Another part of the treatment package was teaching mindfulness skills using various mindfulness exercises, including guided body scans and breath awareness practices. Currently, this learner is guided through these exercises in session using scripts that have been shortened in length when compared to the traditional practices. Additionally, there's visual supports for body scans so that they can reference specific areas of the body as needed, like Alexia mentioned. For guided meditations like body scans or breath awareness practices, we ask questions following the completion of the exercise. This creates opportunities to practice describing their inner behaviors, such as bodily sensations, thoughts, and feelings, while also promoting dialogue to scaffold their education around the mind-body relationship. And then we take data on the answers that the student provides. As an example, during the breathing exercises, we may ask questions like, when you're breathing in, where did you feel the breath go? Did it stay high in your chest, or did it move down towards your belly? And during a body scan exercise, we may ask about specific bodily sensations such as tightness, stiffness, or rigidity in muscles, and ask the learner to describe these sensations in their own words. We did have a loving kindness meditation that focuses on sending feelings of love to individuals of your life, while also focusing on self-compassion and care for oneself. But our learner withdrew assent from this practice early on, as it was very triggering and brought up a range of challenging emotions. So we stopped this practice in sessions immediately and replaced it with a different meditation. And as Alexia mentioned, the goal here is to teach the individuals to independently guide themselves through these exercises by accessing YouTube videos or pre-selected meditation apps once they're able to do this with less support. That way, when they're experiencing triggers in the environment or they're struggling to manage their inner behaviors, they're able to independently guide themselves through a mindfulness practice to help calm their nervous system. So another treatment component was using modified acceptance and commitment therapy. We gradually increased session length and time and decreased the rate at which they came into contact with reinforcers during sessions. And we also used cognitive diffusion techniques to teach them that we can't control our thoughts. And we used a structured ACT workbook to teach how to handle emotions using mindfulness in everyday situations and how to identify personal values to help create a life filled with meaning. We also used workbooks specific to educating them about depression and anxiety through an ACT lens. These workbooks included exercises designed to educate the teens about depression and anxiety, basic breathing, calming, relaxation, and soothing skills, how to identify our own healthy and unhealthy coping strategies, how to set realistic and achievable goals, and how to cope with stress, recognizing strengths, and building resilience. So Bobby will elaborate on many of those ACT methods in her case study. With a more recent decrease in the time spent working on relationship building, we've been able to introduce a variety of traditional learning tasks to address skill deficits. Skill deficits were identified through assessment, and goals were developed in collaboration with our learner by discussing skills that they would like to improve on. Some of the components that address skill deficit areas include teaching emotion recognition in self and others in movie and TV shows, teaching social skills using the peers curriculum, practicing conversational skills in sessions, and teaching social problems in movies and TV shows. So here's an emotions program that we're teaching. And as you can see, this has only been implemented 3 times, but in each session, the learner's rate of response is doubling. The rate of corrects is multiplying ×2, meaning that they're learning very fast. And here's an example of the learner's chart for identifying social problems. The learner struggled with identifying the subtleties of whether a situation was a problem or not, and would begin to describe their decision-making or make comments about the scenes, which was what we counted as X's. So we added visual cues to simply answer yes or no to whether the scenario is a problem or not, and that helped decrease the rate of corrects, or sorry, the rate of incorrects. And so while only receiving 2 to 3 hours of intervention per week since September, individuals in this teen's life have commented on the drastic changes that they've seen since the beginning of intervention. The primary caregiver, teachers, and mental health team have commented on this teen's ability to remain calm, have noted an overall improved mood, and have an increase in prosocial behaviors at school. The primary caregiver has shared with us that they once again started to do more independent activities, such as taking the bus to and from school without support and offering to shop for groceries, which is something that they had never done previously. And so while our time has been relatively short with this learner, if we think about that quality of life funnel, their life is slowly becoming less limited than compared to how it was. And they now have the desire to widen their social network, and they're more open to exploring new life experiences. So they're calmer, they're more able to learn, and they've taken steps towards being in control of their own life. So we know that learning is a lifelong journey, and as they enter later adolescence, we're happy to report that they seem much more ready to sit in the driver's seat and take the wheel of their own life. So the next case that I'll present involves a young boy who is just over the age of 4 and recently diagnosed with autism prior to intake. I am noticing the time though, so I'm probably going to have to cut some of this case study short so that Bobby is able to chat with you guys. So I'm just really quickly going to bring you guys back to this quote here. So what treatment by whom is most effective for this individual with that specific problem, under which set of circumstances, and how does that come about? So for this child here, his learning profile included selected mutism, an impaired mand and tact repertoire, or an impaired labeling and asking repertoire. He refused physical touch. He was inflexible. He was very routine driven. He had lots of task avoidance and elopement. He had food refusal and a very, very limited diet. And he had enuresis and encorporesis, so he wore diapers all of the time. This boy lived with both of his parents until he was about 2.5 years old. And at this time, one of his parents abruptly moved him to the east coast of Canada and then overseas to a war-torn third world country. And in this time, the child lost contact with their primary care attachment figure for an entire year. There's minimal documentation and records of his experiences while living there, but we do know that he lived with a range of aunties and uncles. We're unsure how he spent his days and who primarily cared for him during this time. And after a lengthy legal battle, his primary attachment figure was able to procure a court order to bring him back to Canada. Once back in Canada, he had zero physical contact with the parent overseas, but would FaceTime once per month to maintain some level of contact. He was diagnosed with ASD a few months after his 4th birthday, and shortly after began sessions with our team, both at his home and at his daycare. So if you guys remember the adverse childhood experiences, the ACEs that Alexia reviewed, we know for a fact that this child experienced one ACE in the form of the loss of a parent, and a second ACE is a parent with a significant mental health problem. And given the lack of information regarding his time overseas in a third world country, he may have experienced up to 9 of the 10 ACEs. So I'm going to just quickly go over this one here. So we know that given his complex history, extra care and attention needed to be provided to ensure he was calm, happy, and fearless when he's left to work with his team of interventionists. So we did this by building confidence and trust in his teachers to ensure that he felt safe. So we operationalized this, and behaviors indicative of confidence included joint attention and an audible speaking volume. Behaviors indicative of trust included approaching therapists, orienting his body towards therapist, and spontaneous vocalizations. We also included other verbal behaviors such as labeling his surrounding environment and basic requests using a mix of one-word utterances, pointing, leading, reaching for objects, and moving close to therapists and desired items. And behaviors indicative of feeling safe included allowing physical touch, allowing his parent to leave the room, and following one-step high probability requests. Treatment components. So we did this mostly through non-contingent reinforcement, environmental enrichment through play, and trauma-informed PBS strategies. We use these strategies to become conditioned reinforcers with the student and establish and enhance our relationship with him to teach him that we are trustworthy and safe people to be around. So the first step of our plan included non-contingent reinforcement through play, and this was done both with the parent and just with the BI, but we did this with the parent to aid in transferring stimulus control from the parent to the therapist. The second step was stimulus fading, where after an extended period of play, the parent would move gradually out of the room, and as the parent transitioned out of the room, the therapist continued to play with him as he remained happy. This third step included non-contingent reinforcement through play and slowly introducing work tasks through natural environment teaching opportunities. And the last step was introducing task demands on a continuous reinforcement schedule. If at any point he engaged in any behaviors that signaled distress, he withdrew assent, or he stopped engaging in behaviors that indicated confidence, trust, and safety, then we implemented a calm down plan or a co-regulation plan. So the components of our calm down plans included co-regulating emotions by sitting with him, rubbing his back, holding, rocking him, cuddling him, normalizing his feelings, or just staying in the room with him. If at any point he began to yell or scream, we stopped talking. If he moved his body away from us at all, we would stop touching him. In these instances, our team members would just sit as nearby as possible. And when the student showed signs of social engagement, then we would go back to increasing social interactions with him. A component that was incorporated into all aspects of the support plan was zero physical redirection. And we never physically redirected him if he eloped during a work task. And we never asked him to complete task demands if he eloped during work tasks. So I'm just going to quickly go through this again here, just for the sake of time. So as Alexia discussed, working through those states of hyperarousal might lead to a range of maladaptive behaviors that can interfere with learning. And with a trauma-informed approach, it's really of vital importance for us to first calm the nervous system. So here we're looking to increase the likelihood that in the future, these problematic behaviors will serve as effective communication to indicate that he has physiological and emotional needs that require attention. And we continue to do the calm down and the co-regulation until his nervous system is no longer in an observably heightened state. And we do that by observing social engagement behaviors. Social engagement is derived from the polyvagal theory, and that is a theory that identifies the nervous system response called the social engagement system. When stimuli inside and outside of the body are processed by the nervous system, the environment is perceived to be safe or unsafe. And when environments are perceived as safe, our social engagement system is activated. Social engagement refers to the ability to behave socially in the form of making eye contact, vocalizations, and expressing emotion. So quickly, I'm just going to step away from the case example. And here, this is an example of how we might define social engagement. This is an excerpt from one of our behavior support plans. And you can see that we defined each behavior clearly, going from low levels of social engagement to high levels of social engagement. And we use this to train our BIs to continue calm down procedures until the student is exhibiting several signs of social engagement, and they've moved up the hierarchy and are readily following instructions. This is an example of our data collection sheet where our BIs are taught to tally each of the social engagement behaviors observed, and we arrange the data collection sheet so the BI can easily move up and down the hierarchy. During the calm downs, if we notice that they're moving backwards at all during in the hierarchy, then that's indicative that a calm down is still required, and we withhold in introducing those task demands again. And when we first started incorporating this into our programming, we got concerned that some of our kiddos might make the connection between engaging in maladaptive behaviors and getting out of work. We didn't want to inadvertently teach that, every time I cry or I walk away, I get out of this work stuff and I get to have cuddles. So concerned about running into some problems here, we also developed a system to collect data on this and evaluate whether our calm down procedures would lead to an increase in escape from tasks. So we developed these tally sheets for our therapists to track the number of calm downs per session and the number of times that demand fading was used following a calm down procedure. And what we found to be really interesting was that generally across the board with most of our clients, we didn't see an increase in using demand fading procedures, suggesting that engaging in problem behaviors to access a break in the form of a calm down didn't serve an escape function for them. So our calm down plans are used to provide escape from tasks to calm the nervous system until our clients have the appropriate prerequisite skills in place for us to begin teaching alternative responses through differential reinforcement of alternative behaviors. We use DRAs to teach appropriate responses like I need a break, and additionally, we begin to shift from co-regulation to self-regulation using guided mindfulness practices. So very quickly here, in this boy's case, we didn't need to use a DRA to teach alternative responses or to teach him to regulate his emotions through mindfulness practices. Our time and attention spent on addressing his emotional needs, building confidence, and teaching him to trust his teachers helped him feel safe and resulted in fewer problem behaviors. So to illustrate his growth, we'll share the results of his VB maps. These were his scores at intake, and these were his scores just over 1 year later. So as you can see or imagine, we have a hard time recognizing him as the same kid sometimes. His behavior was so impacted by his trauma that when he first came to us, he was unable to learn in any traditional format. But by using a trauma-informed approach, we were able to bring him from a pretty consistent state of hyperarousal to a calmer state, allowing him to learn. And we're not saying that he's cured from his traumas or that he doesn't become re-triggered at all, but his behaviors are qualitatively different and they don't occur at the same frequency, intensity, or duration. He allows people in his life to comfort him when he's upset, and he's able to independently tact his inner behavior by telling us how he's feeling. He does, sometimes we do see a reemergence of those behaviors that emerge in, so we do see a reoccurrence of those behaviors when the parent that has inconsistent contact with him comes in and out of his life. So we might see a reemergence of aggression, so like hitting, kicking, or throwing items, or screaming, or an increase in counter control behaviors. The difference now is that we can use more traditional behavioral procedures and approaches to manage those challenging behaviors compared to when we first started working with him.
Okay, thank you, Andrea. Am I showing up on the screen?
Yes.
Good, thank you. All right, I'm going to go through this quickly and just focus mostly on the ACT strategies, which I think are, okay, so the case study, we have a 40-year-old male, age 0 to 5, normal development. Age 5, he started to suffer from childhood anxiety disintegrative disorder, which is basically an unexplained complete hypoarousal and disassociation. So he was suffering from sexual abuse from a grandfather, and that continued until the age of 8. And to this day, his parents are in denial regarding that. Well, his mother secretly is not, but his father is. He had an adolescent diagnosis of ASD at age 34. He was antisocial, asocial, basically nonverbal, and had a lifetime of experiential avoidance. And that's when I got together with him. So here's our little funnel again. And yes, and this young man at age 34 was way down in the bottom of the funnel. He had variable challenging behaviors, chronic sleeplessness, bulimia, you name it. He was suffering from it at some point. As we saw him come back out through trauma-informed care, he actually rotated through these behaviors again, which was interesting, but they were short-lived. Functional assessment, lots of avoidance and escape motivated, isolation, disengagement, agitation or aggression, very much hypo-aroused in terms of taking any kind of action in his life. He had attention motivated oppositional behavior and demanding behavior, which was really, he had learned that that was the best way to control an interaction that where someone was trying to manage him. So if we look at acceptance and commitment therapy, we look at this multi-pronged approach, and it's, you know, it's interesting because it tackles all different ways of psychological thinking in our relational frames. So we'll come back to this this chart in a moment when we start to go through some of what's going on. So trauma-informed acceptance and commitment therapy. What we see is that people become identified with the content of their mental life to a very large extent, and that applies to all of us. So disentangling people from their minds is one of the main goals of the ACT. And it started with the relational frame hypothesis, which was really an extension of Skinner's verbal behavior. So what we're trying to do is help people get back in contact with another way of knowing the world, and supporting their knowledge through moving them back into themselves as the context, as opposed to an external context, and using present focus and meaningful engagement to accept that that other mental life will always be in their heads, but that it is something that they do not have to any longer define themselves as. So we started with addressing the experiential avoidance in the first 2 years with trauma-informed support. And I think Andrea did a good job of talking a little bit about how that positive behavior support includes safety, being trustworthy and transparent, and inclusion, collaboration, and mutuality and empowerment and choice, and making that human connection with a rapport that is absolutely encompassed in all of these values. So we had lots of mindful physical activity with some limits, because he did have some stereotypy that was an escape behavior. Although we allowed some, as Andrew pointed out, we can't continue to reinforce that. So, and mindfulness, I've found in my practice, really needs to be adapted to the learner or the person and what it is they can do. And so for him, physical activity was a very mindful thing. So he started swimming, skating, running, and any number of things that his day staff would be able to do with him that really kept him physical. And then we would have a destimulation time after that, where we would then just work at self-soothing and that co-regulation. We would do some response interruption and redirection with differential reinforcement. We use shaping and extinction for social challenges to increase inclusion. And a lot of these social challenges were overtly sexual in nature, and so we really had to work on supporting him to, well, basically putting them on extinction, but focusing much more on differential reinforcement and shaping so that he had alternate behaviors to go to. We worked with him a lot on functional communications because he was pretty much nonverbal. And then we come back to our little hexaflex. So what we're looking for in using these approaches is an increase in psychological flexibility, creating an openness, an increased awareness, and a belief that you can actively work towards your goals and your values. So values were a hard thing because obviously the hypoarousal, the dissociation, he never actually had engaged in any kind of future thinking or values or even himself as the context of those things. He very much did not have himself as context. He was absolutely governed by the external world and had no ability to observe the self, which is what self as context is, and what mindfulness, good mindfulness, will lead to, is to understanding that some of those thoughts that are running through our head did not come from us, and that what we know about ourselves really is only what we can observe in ourselves. And so teaching that is a very important part. The other thing is committed action. And we had to set some goals for him in order to then work with him on what committed action would look like. And a lot of those goals were that physical activity. Diffusion is a huge part of ACT, in where we reframe the content of that relational frame. And we actually give it a label or labels, and then diffuse it with logical explanations that we give to ourselves. So instead of verbalizing a problem, we're encouraged to verbalize a solution or the solution to that problem. And eventually that changes the relational frame. That's one way of diffusion. There are others as well. We had to give him support for PTSD because obviously he had a great deal of post-traumatic stress, and it had gone on for years and years to the age of 34, where no one was acknowledging his experience, and people were trying to control him and not understanding and believing that he actually was severely cognitively challenged, which he is not. So we started medication, and of course, like most clients in this position, he was on a lot of medication. And so we started medication withdrawals to support increasing verbal behavior and our ability to provide graduated exposure and build his insight in the place of fear. So again, that self as context thing, and replacing, not replacing, but acknowledging the constant fear of control by others, which was pretty much what was going on. And with some understanding that that was there, but it didn't have to govern his actions. In the third year of intervention, we worked on diffusion. With the decrease in medication, he started to have many more flashbacks in the form of personal distress, fear, historical behaviors. This is when he started going through the entire repertoire of every behavior that had ever been reported. And they were all facilitated with the naming and reframing, and also with the reassurance that you are safe. What happened to you was not right and cannot happen to you again. And we did teaching regarding the identification and naming of emotional content, because again, he still had quite a bit of hypoarousal. So this was his current functioning last year when we did the presentation. He is in a home share, amazing home share care providers and CSWs. The home share providers have been avid students of ACT, and I've been able to teach them how to work with some of this stuff on a daily basis, and they have just been fabulous with it. So in 2019, he had verbal taxmans and intraverbals. He was working on identifying his feelings and this year he finally got into joking about his feelings, which was really great. And joking about the feelings of others in the family that he lives with. He started engaging with others. He had full eye contact. He had social reciprocal behaviors. Still not a ton of verbal behavior, but enough that he was interacting in a very social way. He was learning to read and write and play piano. So then we planned, okay, for the next year of intervention, we needed to work more on self as context and acceptance, increasing his self-reliance as well as his confidence, and talking about carrying his pain and holding it lightly, and working with him in diffusion in that regard. And letting him know that he is what he values and what he does, and seeing himself more clearly. So looking at him in terms of perspective taking and doing that for him in the beginning, but then sometimes, as I said, even with the emotions where he was joking with others about their emotions, we were seeing that obviously he was learning perspective taking. And then aiming his brain or taming his brain. This is his current functioning now. He's still in the home share with the CSWs. The medication reduction is almost complete. He is now identifying feelings, expressing distress and diffusion alternatives. And just over Christmas, he cried real tears for the first time, which was really moving for all of us. We've done systematic desensitization to multiple flashbacks. We've seen some flashbacks that seem to resolve more quickly than others. We don't really know what they are. He's not expressing them, but times when he can't sleep in his bed and he has to leave his bedroom and go hide somewhere. And you just know he's having a flashback. That's the one that's persevered the longest. Diffusion by labeling and present moment engagement and reassurance, introducing future thinking, and he is disengaging somewhat with his parents, which I think is just kind of a healthy developmental thing. I know he loves them, but I know he also finds them difficult at times. And so he still wants to see them, but not as much. And I made it to the end. So we have a few minutes if anyone has questions for any of us. I think we're all available for that.